to you.
Can I just ask how many people are present at the moment, just for interest?
1, 2, 3, 4, 5, 6, about 8 of us at the moment. Lots of people, lots of interest to watch the recording after that couldn't make it. But yes, I think we've got 8. But as more people, arrive, I will just let them into the room.
Right, well, thank you very much for inviting us. So I'm Julia Robinson. I'm a speech and language therapist. And this is my colleague.
Hi, I'm Kaitlin Fitzgerald. I'm a paediatric dietitian here, and we are from Southampton Children's Hospital.
So we're very aware that ARFID is a huge topic. It's a very hot topic at the moment. And I think part of our aim of this talk is really to talk about feeding difficulties and broaching on ARFID, because so many feeding difficulties have very similar symptoms to.
They overlap a little bit, don't they?
Yeah, to ARFID. They overlap, and actually trying to tease out what the specifics are is very complex. So we're hoping to give you some information from our point of view. We are not based in an ARFID clinic, but we do work with a variety of children with complex feeding problems, and hopefully we're hoping we don't talk too long and that we do give you an opportunity to ask us questions. But we are aware you have sent us some questions anyway, so hopefully we've
answered those.
Okay,
right, let's share this screen. This is much easier than other programs that we've used. Can everybody see those slides?
Yes.
If there's any problems, please let us know.
All right. The only thing we're getting is a little bit of interference with your microphone, I think, sort of a booming sound that keeps coming and going. It sounds like it's being touched or something, but we can cope with that. I just to let you know.
How about we try the next slide, and if it keeps happening, will you let us know, and we'll try and
Okay.
leave?
Yep. All right, go for it.
If it was me touching the keyboard.
Yeah, it could have been.
We've rehearsed this so many times, and then it's the technology we're saying.
Right. There we go.
We've just got a bar in our way, but don't worry. Okay, so we thought we'd just go through the ARFID diagnostic criteria. And as you know, ARFID is quite a controversial diagnosis. So it is very important that from a feeding issue point of view, we actually do rule out paediatric feeding difficulties before seeking an ARFID diagnosis. But we know it's an eating or feeding disturbance manifested by persistent failure to meet appropriate nutritional or energy needs. And it's normally associated, one of these, whether it's significant weight loss, nutritional deficiency, a dependence on enteral feeding or supplements, and there is a marked interference with psychosocial functioning. But we do know that it's not concerned with things like body image, shape or size. It's not concerned with a specific purpose of losing weight or food restriction. We've got a frozen screen.
Yeah, there's definitely so. I don't know if anyone else is getting the noise. Whenever you touch anything on your screen, it's booming at this end.
It's not. It's not even.
Can you still hear me if I've done that?
Just about. I think the microphone's given us a real interference with your voices.
Sorry, we're just our screen is frozen.
Oh no.
There we go. Right. Well, so we know with the ARFID diagnostic criteria, it's an eating disturbance with one or more of the other things, but there are caveats or alongside this. It's an eating disturbance which is not attributable to a concurrent medical condition and not better explained by another mental health disorder. It's not better explained by the lack of available food or associated culturally sanctioned practice. It doesn't occur exclusively during the course of anorexia nervosa or bulimia nervosa. And there's no evidence of a disturbance in the way in which one's body weight or shape is experienced. So in our view, the diagnosis of ARFID is very broad. A lot of children could potentially fit this diagnosis. So it's quite difficult for health professionals, including dietitians and speech and language therapists, to understand the true eating behavior if it's labeled as ARFID. And we'll go through a little bit in a minute how we work this out. So dietitians and speech and language therapists, we tend to work holistically. So a dietitian will do her assessment and then maybe potentially think, okay, what other professionals may need to be involved here based on that assessment, but we'll talk you through that in a minute.
So we also know ARFID can be isolated as a diagnosis, or it can be present alongside other neurodevelopmental disorders like ASD, some intellectual disorders. It is also quite commonly known in children who don't outgrow picky eating. But it can occur alongside vomiting, social phobia, obsessive compulsive disorders. And we know very much the difficulty about ARFID is actually the presentation's variable. The age of the children who present with the difficulties are very variable. There's different weights, as Caitlin's just said. It's all genders are affected, and actually symptoms can be very different, although there are some very specific symptoms. Whereas it was always previously categorized as a feeding disorder of infancy, obviously that has now changed with the new guidelines, but there is a late onset ARFID which exists. And with these type of children or adults, it's very important to ensure the diagnosis is made after a thorough assessment to rule out other eating disorders. And this can often be triggered by school, friendship anxieties, or other anxieties.
So looking at growth status and ARFID diagnosis, so children diagnosed with ARFID or any other selective eating behavior, they can be a normal weight, they can be overweight, they can be morbidly obese, and they can be underweight and totally failing to thrive. ARFID doesn't discriminate, it works right across all children of all different weights. And we notice that a lot of children on the autism spectrum condition, they tend to grow normally. They tend to have really restricted diets, but they grow. But we also notice that over a long period of time, you get chronic undernutrition or malnutrition in ARFID. So these children, their diets are so restricted, and what they're eating, they don't have a wide variety within their limited number of foods. So what happens is over a long period of time, you get something called stunting, which is the chronic, they don't grow in height properly at all. And weights are quite variable, but your heights aren't. So you don't grow long term if you don't get that decent nutrition in. We also note that micronutrient deficiencies in ARFID are often best friends. So children diagnosed with ARFID and other selective eating behaviors can also be at risk of developing deficiencies. So macronutrients, carbohydrates, proteins, and fats. We know a lot of these children will just have beige, carbohydrate-rich foods. Proteins are often the ones, red meat, fish, these are often the ones that are left out. Micronutrients across the board tend to be vitamins B, vitamin B2, vitamin B12, vitamin C, vitamin K, zinc, potassium, and iron. And these are often your essential nutrients. They're found in a lot of dairy, they're found in red meat, they're found in green leafy veg, they're found in legumes. So these are often foods that these children would not even consider eating. The diets are also often low in dietary fiber, so a lot of none of constipation, good quality proteins. So we talk about red meat and fish, selenium, D3, omega-3, and then dairy and calcium. So when we talk about ARFID, we want to just highlight the role of a dietitian in general. So dietitians they can look at growth assessments, they can look at biochemistry, we can look at clinical signs and symptoms, we can look at dietary assessments, feeding histories. It's incredibly important. And we use all of that information to then put a plan in place and give dietary advice. So what can dietitians do for children with ARFID? Dietitians look at the ARFID diagnostic criteria alongside other factors. So dietitians at UHS, for example, so here in Southampton, we are aware and knowledgeable of ARFID, but we are unable to diagnose or manage. So we don't have a formal ARFID service in Southampton. It is my dream to have that done, and we're working towards it, but at the moment we just don't have it. So we are working towards an ARFID pathway in Hampshire. We don't have a formal service for our sensory eaters or selective eating behaviour children in Southampton. There is the CAMS eating disorder service, but those are specifically for eating disorders.
So from a speech language therapy point of view, alongside numerous other aims that we have with our ARFID feeders and our picky eaters and all our feeders, we're looking at the whole caboodle. We're cross-referencing with our feeding history. We're looking at the oromotor skills. We actually like to observe children eating and drinking. And then we're taking the reactions and the processing from those assessments and looking at the way they apply these to sensory sensitivity, looking at food textures. And also we are always bearing in mind language, communication and social interaction. So we know that the feeding history is covered by all professionals, but we all use our feeding history and possibly ask different things within that feeding history and come together to formulate our ideas and management patterns. But why do we assess eating and drinking? So it's really vital that we look at how children eat and drink. We're trying to determine whether there's oral skill problems. We're looking at the difficulty, we're looking at the range, the movement, the patterns of the tongue, jaw and lips when they're eating and drinking. We're looking at those stages of pre-oral, so what happens when they look at a food or actually touch a food, but then looking at as it goes in the mouth, what do they do with their tongue, lips and jaw. And then also looking at that pharyngeal, which is the actual swallow phase, what is going on there. So we're trying to rule out aspiration difficulties, but we're trying to see what else is going on. And it's often noted that actually children with ARFID do not actually have problems with oral skills. But we do know that children with ARFID often gag or choke on foods. Often the gagging is over-reported as choking. And often we have to think, is this choking, is it due to oral skills? Is it a disgust or a sensory response? Is it a pleasurable response? So we need to sort of have a good look at that. Often children will pocket food in the mouth and parents may say they're unable to swallow, so it stays there. This could be sensory sensitivity, could be poor acceptance, it could be due to poor oral skills. And the key thing is for us, I've just realised there's a spelling mistake, to assess how they eat a range of textures, manage different temperatures. And as Kaitlin said, are they looking at certain foods all the time? What is going on? What range do they have? So with our feeding history, this is so key to all of our assessments. So we're trying to sort of find out what your history has been so far, what has impacted on your feeding history, when did you see these problems breaking down? And it also informs the speech therapist when those problems began to arise. Was there a period of overreaction, underreaction? What happens when they are eating? Which foods they're eating? Does your child get very upset when certain things are presented? We're looking at the environment to determine what else is filling into that feeding journey. And it also gives us time to ask you about strategies you've attempted, what works for you. And following on from that, we will discuss the history with your MDT. But there is a stage that children go through about 18 months, 20 months back called neophobia. And so a lot of this discussed, we're looking at when problems started arising and trying to link in with natural development and what we know about feeding patterns.
It's quite common for a fussy eater just to go no when they're introduced to a new food, isn't it? But that gets tricky for later on.
And I think good things for thinking about that is, say we gave you a salt and vinegar crisp. Some of you won't like salt and vinegar, but often some of us will go for the very crunchy ones or the rinsed ones because you like the crunch, you don't like the melty ones. But you know, we're looking at what those textures are giving us so much information about sound. Some people just like Pringles because the salt really rubs on your lips. You know, we're trying to work out what is going on. So when you see speech therapy dietitian and a number of professionals, you will be asked a number of other questions. So we often ask about teeth cleaning, about getting messy, key because we're looking at a sensory side. Again, is sensory oral related around the mouth and head, or is it actually the whole body? So we're trying to sort of work out those different aspects. Obviously, eating and drinking is not just about putting it in your mouth and swallowing it. There's smells, so we're trying to find out about reactions to smells. And also the feeding environment, unless we're eating in isolation, can be very noisy. Some people eat in front of the telly. If you think of school dining rooms, they can be very noisy, very echoey. So we're trying to find out about where your child eats best or does not like to eat, for example. And so again, talking about how they're reacting to taste and temperature, overreacting, underreacting. Do they like everything really spicy? So we're trying to ask lots of questions to inform not only our observations, but actually to get that whole
getting parents thinking about the kinds of things that we're looking at. So the other thing we wanted to chat about are eating behaviours versus ARFID. So there's 4 categories that we generally look at, one of which is nutritional adequacy. So children who are typical eaters or picky eaters, you know, they're around the age of 2, when they call it terrible twos and they start becoming really picky with what they're eating, they don't like veggies. Those children the nutritional adequacy is it's not appropriate for chronological age. They don't rely on nutritional support, and there's very few micronutrient deficiencies in these children. If they're nutritional adequacies, they're not eating all the right things for their age, they're relying on nutritional support. So what I mean by that is high calorie milkshakes, micronutrient supplements. They may be tube fed. They may be getting micronutrient deficiencies, so low iron and zinc and things like that. They may not grow very well. They're more likely to be a progressive picky eater, a sensory eater, or have ARFID. In terms of feeding problems, your picky eaters and your feeding difficulties, you'll find there's a lot of overlap with a lot of these things. So poor drinking skills from the bottle, they're struggling to gain weight, there's reflux, there's back arching, they're fussy with meals, they're fussy with finishing bottles. Meal times are generally a struggle. There's poor progression from your purees to your lumpy foods to finger foods. There's refusal of general family meals at the table. And these meal times are just overall generally a struggle. You'll find that these tend to be for picky eaters of feeding difficulties. Children with ARFID just won't eat them. They're not bothered. Okay. So for skill deficits, the assessment of feeding skills is needed. You need an assessment by a speech and language therapist. These look at the skills needed to eat and swallow, and that helps us define whether, or differentiate whether it's a feeding behavior, feeding difficulty, which is skill related, or of being a picky eater, sensory eater, or someone with a feeding difficulty. So they are quite complex. In terms, the 4th category we'd look at is fear of eating. So consideration of when a child stopped eating, when the phobia began, so whether they have suddenly developed a fear of germs or choking or vomiting. consideration of physical trauma. So we get a lot of children who may come in from car accidents or accidents while skateboarding and have a trauma to their face. And we consider, is the child happy to eat with their family or with their peers? Do they not want to eat with school friends? A lot of these children with a fear of eating will have ARFID. You may see some, a variety of these fears in a child, but generally your picky eaters and your ones with feeding difficulties don't have a specific fear of eating. Theirs is more skill-based. Okay. But the ones with fears will generally have the ARFID. So one of the things, I think my child may have ARFID. So one of the things to do is to discuss your concerns with your professionals, the team around you and your child. Discussion is needed to explore the difficulties and formulate a hypothesis so that we know how to manage your child going forward, and you know how to manage your child going forward. So based on the discussions with your team, you may have a referral to a dietitian, you may have a referral to a speech and language therapist, you may have referral to a pediatrician or for a CAMS assessment. Generally, a referral to a pediatrician or a CAMS assessment is the first line before a dietitian and a speech and language therapist. And it may, the service is quite different and every child's individualized. And I think from what we've said so far, we can see how complex these children are. Generally, what happens is these children get referred to a pediatrician or they have a CAMS assessment, and then they get a referral to a dietitian or speech and language therapist if that is needed. They say it is not ARFID. What do I do? So if your child does not have a diagnosis of ARFID, this does not negate their feeding difficulty or eating behavior. Okay. To help inform your team of your concerns, what we'd advise to list make a list of all the behavior concerns. So these might include various different things. They might include, children not tolerating textures or materials and different things like that. To keep a detailed food diary, so exactly what these children are eating, what times, what amounts they're eating, and then a list of preferred or accepted foods, so foods that are absolute they will eat without a problem, even if these are 4 or 5 foods. We would also recommend to persist with the recommended strategies. Managing a child with restrictive eating behaviors or ARFID, it's a long journey. It takes a very long time, and the strategies are often going to be the things that we'll repeat over and over again, because this is how we manage them going forward. So what we would say is don't give up. Accept that your child's feeding journey is different to that of others. This is a huge thing we find for parents. Liaise with your team for further support if it's needed, and manage your expectations. So we had a discussion with the parent a couple of days ago, and they wanted their child to eat like every other child. And it's getting this parent to understand that that's not going to happen, but that we can put plans in place to help this child eat a little bit better and to increase that dietary variety. What local help is available? So as I've said before, there is no formal pathway for children with ARFID as inpatients or outpatients in Southampton or Hampshire. There is a Hampshire CAMS eating disorder service available, which supports patients with ARFID over the age of 5. Southampton Children's Hospital, we do have a general clinic where we see some ARFID patients. The Hampshire CAMS eating disorder service is predominantly OT dietitian led and has some psychological support within the wider multidisciplinary team. So it provides support for children who are of low weight or have weight loss or micronutrient deficiencies. They require full blood tests and observations before they're seen. So that's as part of the referral. The OT looks at providing sensory intervention and graded exposure, while the dietitian assesses your nutritional risk and makes growth and nutritional recommendations. And the dietitians at Southampton Children's Hospital will also do that. But the Hampshire CAMS eating disorder service is probably the team to go to for that. We are aware that some children are referred to other NHS or private feeding clinics across the UK. We aren't able to recommend them or refer. So you discuss this with your local team if you feel that a referral is what is what's needed.
So let's talk about some practical strategies that we can use with children with eating difficulties, and some strategies that can be applied to a lot of our children across the board. So we know that all children have different appetites, even adults. So we're all very different. So take that on board. It's really important that as a parent, you're showing pleasure in the food being eaten. I think the whole meal times get very stressful, and often we can lose that side. And actually, it's eating in front of some children. Some children may not like it, so we have to be very cautious. But obviously, if we can show pleasure in food, that does actually have some influence on our children. We can talk about food in a positive and relaxed manner, focusing on the taste. Not that you must eat this, it's healthy. We talk about food in being different colours, different textures. So we've got a little slide on the next one about mealtime chat. So it's just to sort of enable that positive talking about food. We can talk about biscuits being crunchy, or oh, it's all broken up in my mouth. We can talk about colours, we can talk about shape and size, we can talk about temperature. So it is really important to sort of try and bring that into your mealtime chat where possible. We do also talk about giving small portions of food, small taste, because we know that presenting a large dinner for a lot of children can be overwhelming. It also accepts the expectation that actually this is the amount you eat. It's not this whole overwhelming visual large meal. We're sort of talking about offering age-appropriate foods, or actually foods that are appropriate for your oral skills. So for those children who can't chew, we are looking at making food softer, easier to chew, or even going back to puree to try and get that interest in taste and development. Obviously, you've got your home-cooked foods and your shop-bought ones, and we know that different brands cause different problems for children. So it's trying to work out what the range, the texture and the brand is. We're sort of trying to say, actually, if you can involve your child in mealtime prep, whether it's setting the table, if you can do a bit of washing your carrots, or involved in some early preparation for making the meal, or even shopping, taking things out the fridge. There is some evidence that shows with a lot of children, this is actually very useful because they're getting exposure. It's all about exposure and desensitizing the looking, the smelling, those sort of sides. With children who will sit at the table, we'll often use what we call a sharing plate, where you have a small amount of a food that you would like to be looked at or tasted or touched, whereby it's in the middle of your table and you pass the table round so everyone can either take a bit, either with their hands or with a fork, or just have a look at it. So that helps with exposure as well, but also you're seeing other people eat that food, touch that food. So you're sort of trying to decrease any oversensitivity.
You're building that trust, aren't you?
So eating with your child, if they will tolerate it. The key thing is not to force feed your child. Obviously, you're under pressure. Sometimes there's a lot of concern about weight. So it does get so intense, and we do understand that. And having been there ourselves, we sort of do realise that, you know, it is the natural side, but it is the one thing we really need to try and work out how we can decrease that anxiety in ourselves. And obviously not pressurising your child to eat, or offering a reward. If you eat this, you can then have a chocolate, or if you eat this, I'll get you a prize. It's trying to reduce those. But these are all natural things that we all fall into. And so we've talked about the mealtime chat. So another strategy that we do recommend is messy play. And there is a variety of messy play. And messy play with food is very much a hot topic and very much recommended. But I will say to you, from a speech therapy point of view, do go back and think about water play, sand play, Play-Doh, all those what I call the old style games are just so important, playing with leaves, all those sorts of things. But the aim, again, is to learn how textures or food items or drinks, how they look, they smell, how they feel, how their properties change if we add a little bit of water or a little bit of glue. And so we're aiming to try and do this without focusing on eating and drinking. And you can play with food items like making face pictures, painting with carrot sticks and that. But I think what is a problem that I seem to be seeing is that a lot of children will play with the carrots, they'll pick them up, they'll put them in their toy car, they'll drive them away, but it hasn't moved on from there. So I think we have to really think, no, won't even put them to their mouths. So I think it's making sure that there is an aim and a structure on how to progress with these things. So it is really key that we try and work out what our aims are, how we move it forward along the feeding journey as well. And often children will prefer to use dry textured foods for their favourite toys. And then we try and sort of move it on to sort of trying to get them to touch with a different texture, moving on to wet, such as kneading or doughing or rolling out pastry, but you can do that with your Play-Doh. And then obviously adding liquids as sauces, preparing together, cooking. So there is sort of a little graded way of looking at it, but actually that does not work for all. So I have mentioned about food exposure, and actually food exposure is key. So this is obviously, like we talked about, the sharing plate. So exposing to a new food or a tolerating food is so key to sort of our journey. And we talk about exposures are not easy. They can promote high emotional responses for both the adult and the child. And it's easy to get very discouraged if exposures don't go well. But hopefully with your team, we're trying to work out what foods we can work on exposure to. So often we'll say try and stick with it, because desensitization can help adjust that. And certainly food exposure can just be looking at it when you're shopping or having it on the side but not actually touching it, to obviously exposing to sort of touch or actually on your plate. If it's on your plate, we'll often say keep your foods in rotation, because once you can tolerate a new food, you can add it into your rotation. Often by rotating foods, you prevent something which we call food jagging. So hopefully we'll talk about that in a little while. But sort of try and keep that rotation going, different foods, introducing new foods once or twice a week. So you aren't doing this so you can increase the chance that you'll need to repeat this exposure from time. So we know that certainly trying to maintain that rotation aids that.
They carry on eating that food,
yes.
don't they?
Sorry.
Yeah, giving it more of it.
So again, including your child in your decision making. Some children, it's not for all, and obviously we're aware that there is this very different continuum, but you can certainly say, oh, what shall we look at? What shall we try? What shall we use this week? So you can actually try and get them, or is there a food that you would like to have a look at this week? So then you can include them in the planning, work out what they're curious about. Their friends might have something that they like. So it is very much trying to make it more of an adventure.
Yeah.
If they're on board, often you get more success. And actually making it a shared family experience can increase that openness and willingness to try. But as a parent, it is key that we take care of ourselves, because obviously this is very stressful, trying to work through this, trying to be on top of it, trying to think about all these different strategies. So it is really important that we look after you and you look after yourselves as part of this process of feeding.
So with ARFID and various eating behaviours, there are feeding approaches and strategies that are available and used across they're used in the States and they're used across Europe and across the UK, but they're very individual and not all of them are suitable for ARFID. So for your slightly selective eaters and your fussy eaters, these are a lot of the approaches that can be used, like the food adventure model. These are available on websites, and they talk about what we've spoken about earlier, is exploring food, exposure, children learning about foods and all the sensory properties of those foods so that they learn to trust them. And circle of security, positive role modeling is how parents react with their children in a mealtime and how secure the child feels within that mealtime. So you'll notice a lot of these approaches are holistic. They're not for everybody, and I think it's fine discussing with your professional what you think might suit. One of the approaches, and we'll speak about it in a minute, is food chaining. So food chaining is a treatment approach that we use to introduce new foods to children while building on a child's past successful eating experience. So, for example, if a child is presented with a new food, food chaining, if a child eats a particular food, food chaining would then mean that we offer them a new food which is similar in the taste, the temperature, and the texture, but it just happens to be a new food and there's a different element. So similar foods are used to create food chains, and the links between these foods a child already accepts, and the new targeted foods that we would like the child to eat. And the aim is to expand the diet and have the child eat the food, but not necessarily all the foods, but foods from all food groups and ones that they enjoy. And often you'll find we do this with protein containing foods because we struggle to get these in usually.
And within our food chaining, we'll use flavour mapping and flavour masking, but we do have to be very cautious on how we do this because we don't want to hide foods. So flavour mapping is where we would look at a child's preferences, we'd look for patterns between the child's favourite foods, looking at that texture, and then trying to sort of work out similar textures, similar flavours. And moving along that continuum. But we will also mask a flavour, so we will use a transitional food using a favourite food. So for example, if we're trying to get a child to change to a new food, we may well use, if they like tomato sauce, for example, we may use tomato sauce as a dip, or we may actually expect a little taste of the new flavour followed by the food that the child will eat. So we're going to try and grade it so it's similar flavour, but then they will eat the main food that they're used to and have another taste of the other food followed by a bite of the main food. So we do try and work out different ways to encourage, but also sort of mask so that taste doesn't stay for too long until we can grade that time between. In terms of flavour masking, as we've said, certainly it can increase the approval of foods, but again we have to be very cautious that by using tomato sauce we're not overriding the senses and actually masking the taste of a food or the texture, because it can change that. So a good example is making tiny changes. Say they'll eat McDonald's fries, so we want to try and get the home cooked fries and make them more like a French fry if it acts more like McDonald's. Once we can get those in, we might then change trying to chips, onto chunky chips, onto croquettes, to mashed potato. This will take a long time. We're not saying it's an easy journey, and we may only add a few pieces of a new food at a time, but be prepared, it will take time. It is very sort of draining for adults to, for parents to go through this, and you do need a lot of support, but do be patient, talk about those positives that are occurring, and hopefully we can go along that journey together. And another example there is sort of trying to get chicken nuggets to fish. So having your favourite nuggets, then sort of you can see there's even a colour and the texture change already on those fish nuggets.
This is the quick version.
Yeah. So this is very adapted. So from your fish nuggets onto your fish sticks, onto fish that's baked, onto fried, and then onto a patty sort of type. So again, it's, although it looks that simple, we're aware it definitely isn't that simple.
One of the approaches, which we didn't mention earlier, that we commonly use, and you'll find, if you Google it, you'll find something called the steps to eating, which is part of the sequential oral sensory approach. And the steps to eating is a step-by-step guide to reintroduce new foods. And it's different to food chaining in a way. So it's an element of the SOS approach to feeding. There's a huge copyright on it, so you have to do the course in order to be able to follow the actual step-by-step guide. What we like about it, it's 32 steps. So again, it's a long journey, but it shows how complicated eating is for our sensory eaters and our ARFID children. It's not a therapy program, and you can't be used on its own. Okay, so the steps to eating, it's designed to use with the whole SOS approach. It looks at the stages of looking at the food, interacting with the food without directly touching it. So there's no pressure on this child to eat this food at all. They just have to be able to look at it. They have to be able to interact with it and, you know, look and talk about the shape and those kinds of things. Then look at the smell of it. Touch the food with their fingers, their hands, their body, their mouth, how it feels, because it will feel different in different parts of the body, and then tasting it. So what we wanted to go through as well is often questions parents ask us. And one of the questions is, my child doesn't want to touch new foods. How we manage this is some children are very sensitive to touch, okay? And what we need to do is find the textures they don't mind touching, that they're quite comfortable with. So if they really like chicken nuggets, you might find they don't mind touching a breaded nugget, that kind of sensation. So we find similar but slightly different textures. You might find that if you had a chicken nugget with a crispy crumb, you might find that a different brand, the crumb is slightly different. We try and choose new foods that are similar to the ones they like, so that it's not too much of a drastic change between the two. We make the verbal connections. We talk about how it smells, how it looks, what the child likes about it, what the child doesn't like about it. We can start with non-food play, so just touching it with zero expectation that they eat it, and obviously you build up. And they can try a utensil, so they don't have to touch it with their finger, but they can maybe try a fork. Okay, and you can start with one food and then build this up over time.
And it is quite similar to food chaining, yeah, isn't it, on this sort of aspect?
Yeah. Sometimes parents ask us another question. My child eats the same foods every day, and I suspect many parents can appreciate this. So we ensure that there are some foods your child likes at every single mealtime. Okay, if you were to offer different foods, your child would just be like, no, we're not eating that. But they're more likely to engage if they know there's foods they know and recognize and are happy to eat. So you offer a few foods in some bowls in the middle of the table, and they can have control over what they want on their plate. You're also looking at the portion size. So you don't want a massive bowl of peas. You want maybe a bowl with 1 or 2 tablespoons, so little portions, so they don't get overwhelmed. And this gives the child a sense of control, which is rewarding. Often children at those particular ages, the thing they have control over is food. And they can hope, I want to try some of that, and I want to try some of that. So that sense of control is rewarding. This approach also offers the opportunity for exposure to foods without the added pressure. So like we've said, they're not expected to eat it, but they get exposed to the different food. They can learn about the tastes and textures and talk about it without being forced to eat it.
So another question parents will ask is, my child will play with food but will not eat it. And I think we've already said about messy play can actually overlap here. But we do know it is important to let your child to explore food. Food should not be thrown around the room though. So we do get a lot of that picking up losing. So it's trying to re-explore what is going on there, and we do know that is a natural stage of development as well, so we have to sort of look at it in detail. But we will often do dip, so using your fingers or touching it, dipping it in something, prompting squashing, prompting pressing, showing them what to do as well. Prompting if they're picking it up, oh, can you smell it, can you lick it, can you kiss it? So it's trying to sort of encourage them to look at that food but take it nearer as well, but in a very graded way and in a playful way. In terms of exploration, we've talked about how key it is for you to be talking about the food, so looking at colours, the textures, smelling, all with this positive emphasis. And the key thing about food being out, if it is play with food, take it away after a set time. Do not let this extend. It's there for a purpose, but it's not to be drawn out until they've actually touched it. If they're not interested, just take it away. So another question, my child will not eat their usual foods. So often this is called food jagging. So where a child eats a lot of a certain food or a certain number of foods, then all of a sudden they don't want that food. So they wake up, no, and they're refusing that food for quite a while, for meal after meal. So the danger of always presenting the same food, which is like we like food rotation, is because actually we all tire of certain foods. So this does happen in children as well. So we're trying to prevent this food jagging by going through a rotation of foods. So certainly children go through this phase naturally, so it can be part of a typical development. We know that children who are picky eaters will tire and will food jag, but usually if we return to that food, put it in on a small amount on a plate or in a bowl, after 2 to 3 weeks, they will usually go back and put it back into their repertoire. Whereas sometimes with a child with ARFID, that may not be put back in their diet. It may be totally eliminated for some reason. So we do know elimination in theory is not a significant concern if it's of a few foods and there's still a range of foods, but the child who is allowed to food jag for an extended period of time will significantly reduce the number of foods in their repertoire, and this could cause nutritional deficits. So we also know that children usually have a good 30 foods in their diet that they accept for a majority of meals. So we can sort of, if you think about that's meals and snacks, so you think about 3 different foods at different meals throughout the week and 2 snacks a day, so you can get your different foods in, and it's the amount of accepted food that is important for the child's nutrition and overall development.
So one of the other questions we were asked is, my child will not take their medicines. Now, unfortunately, if I have an overnight cure, I would give it to you. If your child refuses medicines, you need to speak to your health professionals, your GP, your pharmacist or pediatrician. There may be an alternative you can try. Otherwise, there are maybe some strategies that you can try, which I'll talk about in a minute. If your child refuses a multivitamin and mineral supplement, consider what's been recommended by your health professional, consider what they need, and consider the various forms available. So from my experience with children with ARFID and selective eating behaviours, we like them on a multivitamin and mineral supplement, because they're often, they miss out the essential foods we need them to eat. But these children are very selective about the kinds of vitamins and mineral supplements they will take. It's to note that a lot of supplements and a lot of ones children will take have gummies. The majority of your gummies just have multivitamins. They don't have your minerals. So you're like your zinc, your iron, selenium, copper. Tablets, general A to Z tablets in a pharmacy tend to be very well stocked in terms of what they have in terms of multivitamins and minerals. Chalky chewables tend to be very good. They have multivitamins and minerals generally. Sometimes they have omega-3 added. and there's different brands available in all of these. Sometimes you get an effervescent with multivitamins and minerals. There will be a range of products, and they all have a range of things in them. What's important to note, though, is what's available in the different certain types of products. The syrups are variable. They're the ones that probably vary the most, because some will just be multivitamins, some will be multivitamins and a few minerals. In certain cases, very rare cases, dietitians will prescribe, I've prescribed high calorie products, milkshakes and yogurts for a child because they weren't meeting their micronutrient needs, but that's often one of the last resorts that we'll try. Generally, we try and get a multivitamin mineral supplement in. We can also try products at home for flavoring, so things like yogurts. I often say if parents are going to try a new flavored squash, a new multivitamin syrup, for example, and they'll drink squash, buy a new flavor of squash and always give those two in a really strong flavor, and always give those two together. Tends to be that if you give your multivitamin syrup with a different squash, your child will know straight away and will then refuse. So it's trying to find a little trick that works for you, and that's the same for medicines as well. So you can add them into yogurts, you can add them into juices and squash and puddings, apple purees, things like that. We also note the multimedia is quite useful for children, especially when they're learning about foods, when you want to encourage them to learn about foods and talk about foods. So there's loads of fruit and veggie songs available on the internet at the moment. There's lots of vegetable apps where they learn about the different textures and types of veggies. There's a Fun with Food program. My personal favorite is something called Netflix, I'm in the Mood for Food, and it talks about children trying new foods, what they go through when they're trying a new food. And I quite like it because it's got always different characters in it, but it's also useful for different ages.
But if you're very sensory, it is quite overloading.
Music go slowly
and visually. But there's, just talking about the vegetable apps, there's things like vegetable maths and things, and there has been some research that shows children using these apps actually show more interest in food and in those different foods. So it is quite interesting, some of the research that's coming out, and obviously we're sort of trying to monitor all the changes that are going on with multimedia, because there should be some interesting research coming.
One of the other questions that we had was the process for tube feeding if required. We haven't put this in to scare parents. Our goal is to highlight that this is a last resort. It's very, very rare that we will tube feed patients with ARFID. Generally, the first line of management that we would do is multivitamin and mineral supplements and working on the strategies. Children are tube fed for various different reasons. It's not just growth or micronutrient supplements. Feeding tubes can be given for long or short-term feeding. You know, there might be a couple of weeks, there might be a couple of days, there might be a couple of years. And it depends on the condition and what we're dealing with. Often what we find is we start child on a tube. It's great, the micronutrients are met, but we can't get the child off the tube. So what we often need when a child is first tube fed is an exit strategy. This is a medical decision. It's not taken lightly, and it's often used as a last resort. There are no set criteria for tube feeding, but some reasons may include poor growth, unsafe swallows. It may be condition-based. So if you've got if you're a respiratory child, for example, and you struggle to breathe and eat at the same time, there's lots of different medical conditions that we start children tube feeding. If you really, really feel this is the way that you would like to go, you need to speak to your local team or your pediatrician, and they can assess, and then they may refer onwards to a pediatric surgical team. So just to very quickly highlight the different types of tubes, there's several different types, but there's one that goes through your nose, down the back of your throat into your stomach. There's one that goes straight into your tummy, and there's one that goes straight down into your large intestine. So there's different ways of feeding for different reasons, but we try not use this as an option for children with ARFID. Thank you very much for listening. I hope we've answered all of your questions, but we're more than happy to take any questions if there are any.
I think we have gone over. Sorry about that.
That's all right. Thank you so much. We have been trying for a few years to get someone to come and give us a talk on ARFID. I'm so delighted that we finally met the right people, and I've learned a huge amount. I'm thinking for my 10-year-old who has eating issues, very much how I can support her. But I'm also wondering about sort of teenagers with that very rigid thinking, how we approach some of that for those people. I guess it's maybe using similar strategies, but leveling it up a bit to sort of the older needs. And I know for a lot of our families, those with autism and that rigid thinking and teenage years combined can be really, really tough to get, the right food into them. So I'm just gonna see if anyone has any questions. If you do, feel free to unmute yourself or put them in the chat.
Yes, please.
Go for it, Jo.
Had to be me, didn't it? I'm a bit confused because one part of the slides say that CAMS eating disorder team can't diagnose, and then it says your pathway go to a paediatrician or CAMS.
So CAMS can diagnose.
Yeah.
But dieticians can't.
Right, because my son got diagnosed by CAMS.
Okay.
With ARFID, but we've also got referred to Great Ormond Street, so it's a bit of conflicting. But obviously we're back on, it's a bit confusing, we're now back onto Southampton with your team and everything, but it's sort of like the same thing like with messy play and food training. Now with my son, we've done like the food mapping, we've done the food training, I've been on so many courses, it's unbelievable. I always pick up something new, which is great. But with him, when you food change, like you go from McDonald's to like French fries, one, he'll notice a difference straight away. He's not interested in food. He's just not bothered. He never says he's hungry. But as soon as we try to food change, then those McDonald's chips go out. It's sort of like,
so they reject.
It's really hard to explain. And it's like now, yes, we're down to one food. He'll only eat one food now. He's on supplements, which isn't great because he doesn't like them. But it just seems like every time like you put like in food chain and food mapping, introduce, even if I put another food on the table, so it's sort of like I get told by Great Ormond Street to never take a safe food away, but then I also have been told by Southampton to take a safe food away and put new foods. It's a bit, when you just really don't know where to go and what to do anymore.
I think thank you for your question. I think it's complex. I think we can.
I've been fighting this for years.
So how it works at the moment is we have there's Hampshire CAMS team.
Yeah.
They can diagnose, but there's no management service.
Yeah, that because they referred us up to Evelina and Great Ormond Street.
Yeah, but they have feeding clinics, and that's why you got referred.
Yeah.
This is where we do struggle in terms of managing ARFID patients, particularly those ones who are really restrictive. And it's
don't get me wrong, Southampton have been great and they are supporting us. And yeah, we've had a few blips. I'm due up there pretty soon, actually. But yeah, it just seems like I understand, like you say, with food training, food mapping, but nothing seems to work. He won't get messy because he's autistic as well as other things. He doesn't like smells.
So he wouldn't tolerate being in the same room.
No. He's got better, don't get me wrong, but he's now 11. It's taken a good 8-9 years.
Yeah.
Before he wouldn't even sit in the same room as me having just a plain roast dinner. I can understand with spicy foods. He tolerates it sometimes, but not a great deal with what I call plain meals, with me sitting and eating. Usually I sort of go up and sit in the kitchen or go up in my room and eat. I feel like I'm in a bit of a bed sit, if that makes sense. Even at school, he can't sit in the same room. Even talking about food, he tends to reach, gag and probably throw up, and then that food's out of the window. So that's why we're down to one food now, which isn't a lot.
And I think, like you're saying, there is an extreme sensory overload there, which with not just visual, the smell, you've got everything going on. And I suppose, can you go back to your team who advised on the chaining to get them to talk to you more about that chaining? Because have we gone too quick with that, or?
No, like I said, I've been doing it since the age of 2.
Yeah.
I've educated myself because there was literally no help whatsoever.
Right.
And I'm quite a proactive parent. I've educated. He's been under CAMS for years. We eventually got the diagnosis, which then I thought, yeah, perhaps he's borderline, but no, it's the worst case they've seen in Southampton. But we just don't seem to be, there's no occupational therapy involved. I've done a sensory course, but I'm not a professional. It just seems to be left. You're put on courses and you've got to deal with it.
Jo, I'm really sorry to interrupt, but I don't think we're gonna get the answer that you're hoping for just from this today. So I think the advice, of going back to your team and talking to them again. I'm only sort of interrupting because we've got a couple of other questions that we need to get to, and I know we're sort of limited for time now. So sorry for jumping in.
I think it does show how difficult it is, doesn't it? It's a very good example.
Yeah, absolutely. Someone's asked in the chat if could have a little bit of input about how you do approach this with teenagers, and what do we do with those really tricky and often autistic teenagers that we're dealing with.
So I think we have to think, what is the aim?
Yeah.
What are you trying to achieve?
What do you want to achieve?
Yeah, what
do they want to achieve?
I mean, is it more that you want to increase their range, or what do we do? What specifics around your question? Is that?
I'm not sure. I guess if I don't know. I don't want to weight and nutrition. There we go. Weight and nutrition.
I think maybe it's difficult with an autistic young person because often they won't talk about it. But ideally, if you want to work out what you want to work out and work out what the young person would like, then you have a bit more of direction of where to go. You can monitor their weight, and if they do have a weight problem, you can go to your GP and get help for that. I think it's been quite practical about what needs to be done. Does that make sense?
Okay. Yes.
A good way to start as well would probably be a bit of a food diary, so we can actually look at not just, they eat this. Quantity, I suppose, would be really helpful for us to sort of look at and think about that, and then ways we can add in extra calories to that of their range of foods. I wonder if that would be quite useful.
Helps us realize how much of a problem this actually is, if that makes sense.
Yes.
Yeah, and how you can tailor.
Yeah, whether also is there the opportunity for increasing the quantity of the foods that they are eating, whether it be via a bigger snack, for example, or whatever. Are there opportunities to be able to sort of increase the range? Because I think it's looking at as well what they are actually eating, and then how we can either make that higher calorie within that range, or like you say, taking it further and looking at Caitlin's just looking at the questions.
Brilliant.
Just looking at how we can sort of increase that quantity. Are they quantity specific, time specific, but can we change that in any other way, I suppose, and looking at those foods, whether we need to get some of those foods in a bit more regularly or something.
And I think if you're noticing things like mouth ulcers and they're eating really poorly, that requires a GP visit. That needs something doing about it, really. A food diary will be a really good idea, because that you have a better way of what's going in, how much is going in, and what needs to change from that. In terms of multivitamins, I think it's trying loads of different ones and trying one that will be taken. There's different sizes of tablets, there's different chewable ones, there's syrups, there's sprinkles, there's all sorts of product, and it's finding one that he will take to manage that. And it's working with what you've got, unfortunately, and trying to make the best of it. We've had another question. Dietitians cannot diagnose ARFID. we can help manage it. Dietitians within eating disorder services do help manage patients with ARFID as well. If you, again, like we've said before, if you feel your child does have ARFID, speak to your local team, and if they feel the assessment is needed, they can refer onwards. Okay.
There is another question as well about can't get a formal diagnosis because weight is fine, and I suppose that is a common issue, and I suppose it's, you know, what it's trying to find the reason that you need that referral, because it does diagnosis, it does help, but we'd often say if they're eating, their nutrition's good, we won't really worry too much. In fact, we won't worry at all, really.
They're going to have ARFID for life. That, you know, they're going to have a restricted diet for a long time. It's just managing and doing what we need to do to keep them as safe and nutritionally well as possible.
Having your child's wider environment, understand that, because I know lunch boxes and everything else cause big problems in schools, don't they? So it is trying to sort of get everyone on board to accept that as well.
Okay, so I think for the mum who's worried about her child not having a diagnosis of ARFID and being really restricted, again, what we say, list all of the foods he eats, every single one of them. Do a food diary, work out exactly what he eats and exactly how much he eats. Get a referral and then take that forward. That would be your first step. Okay.
That's really helpful. Thank you. I've learned, so my brain is, I'm ticking over.
There is a lot to cover
of all the things, and
the complexity of it.
Yes, and I guess still that kind of is, we're not going to know whether or not it's ARFID. We need to, you know, go to you guys. You're going to be the expert. So if we're worried about all of those things that you went through, then I guess our next step is to get some advice. And I really like the idea of keeping some food diaries and all those practical ideas you gave us. I'm going to be taking away and sort of working my way through, because I guess that would help if we can come, you know, if we're going to make a referral, if we can come with things that we've already tried, that, you know, I'm sure would help. Thank you so much for your time. You must have spent a long time putting all of that together. So we really appreciate it. I know it will really help, you know, families who are struggling and couldn't get to the call today. So thank you ever so much for your time. Really nice to see you. Thanks everyone for joining us. Take care.
Thanks.
Bye-bye.
Bye-bye.